Hello, everyone. Thank you for joining us. We'll get started in just a few minutes. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The planning committee members and speaker have disclosed no relevant financial relationships. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available on the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We'd like to thank our speaker for sharing her expertise with us today. Our speaker today is Dr. Karen Foley. Dr. Karen Foley's work is bound together by the lens of psychological trauma. With this theme, she has received funding to support investigations surrounding trauma-informed parenting for kinship parents, relationships between trauma and substance use in nurses, and nurses' trauma and cognitive control. As a nurse theorist, Dr. Foley conceptualized and disseminated a middle-range theory of nurses' psychological trauma. She is also the recipient of numerous research and teaching awards and is the co-author of The Influence of Psychological Trauma in Nursing, published in 2019. We are so thankful to have you today, and welcome.
Thank you so much. I'm so honored to be here. Very much indebted to Sigma for asking me to present this webinar today. Why don't we go ahead and get started? And a welcome to everybody in the United States as well as other countries. I look forward to our discussion. So the title for today is Nurses Patient, Individual and System Implications. And this kind of started when I wrote a blog for nursology.net. I don't know how many of you are familiar with that website, but it outlines some of my thoughts preliminarily about situating the nurse as patient. And then I was invited by Sigma to go ahead and do this webinar, and I was able to flesh out some of those ideas in a little more detail. So what I'd like to cover today, and what I hope you can gain after today's discussion and presentation, is to critique the assumptions that I'm going to forward in just a moment about how we see nurses as possible patients. We're going to describe the 3 E's of trauma. This is a model that SAMHSA forwarded in 2014, and I think it really speaks to how we can think about psychological trauma in a way that might be helpful to nurses. 3, I'd like to propose an intervention based on the nurse narratives that describe nurse-specific traumas. And I'm going to outline very briefly the theory that was just mentioned, the nurses' psychological trauma theory, middle range theory. And I have found, I've spoken quite a bit about it. I'll add that it was formulated, the genesis of it was pre-pandemic. A lot of folks think that it was created after or during the pandemic, but it's really was before that. So I think that's kind of interesting. And then we'll synthesize the implications of nurse as patient at the individual and system levels. We'll talk about maybe some interventions as well as what can be accomplished when we think about nurses as recipients of care and comfort. So I always, like as a writer, as a presenter, as a teacher, thinking about thesis statements. And that means the principal idea that I'm going to present and defend as we talk. And then the assumptions surrounding that thesis statement. I think it adds clarity as the presentation unfolds. Let's take a step back and talk about, well, how nurses are viewed. And I think that there's a real continuum as to how nurses are viewed today by society and globally. We are seen again, I don't know how many years, at least 20 years perhaps, as trustworthy, ethical, honest by society. Gallup poll says we are, right? In contrast, sometimes some of the health systems and health organizations see us as an expense on the budget. We do not individually code and bill as other healthcare providers do. And therefore, sometimes we get a little bit lost in terms of our value in an organization. We are viewed en masse. And by that, I mean we're seen as a body, a group. We have a long history, a humble history of being female dominated, although that's slightly starting to shift just a little bit. I think the last statistic I read, we are about up to a 11% male population of nurses. But I think if we go back to some postmodernist terms, there can be an objectification of nurses as a group. And I'm thinking primarily of those frontline bedside nurses. We refer to physicians as individuals, but rarely do we refer to the bedside nurse as individuals on a typical basis. And I think that that's important to note as we continue to talk. So my thesis statement is this: viewing nurses as patients, as persons in need of mental health support and services, as well as physical, creates a new discourse. It's a new language, right? And that's something else that my theory did. It created a new vernacular for folks to use as they were trying to describe their experiences. And what this language, this discourse allows practitioners, educators, researchers, and policymakers to do is to talk about strategies, to kind of focus in on interventions, to support nurses and their mental health needs. And then concomitantly, at the same time, talk about really benefiting the organizations. And I'm going to talk about retention in a while too, cost to organizations. Further, the unique genesis of nurses' mental health needs may be examined within this discourse. So what in the heck do I mean by that? I mean, who is culpable. We talk so much right now about resilience, and I'm all for resilience. I'm a cheerleader for resilience and resilience training and the development of resilience. But I would also add to that that organizations and the contexts that they provide for nursing care or nursings to deliver the care that they render can be somewhat culpable. And I'll talk about that in a minute, and responsible for some of the mental health issues that nurses face. And certainly, by using this discourse of nurse as patient, nurse as person in need, we can look at the organization in a different way as well in terms of providing support for those needs. My assumptions are this: situating nurses as persons and patients allows us at the individual level to provide a plan of care for that person and nurse, to account for the roles that nurses take on: bedside providers, supervisors, students, and faculty. And at the system level, recognize and respond in informed ways to support retention of nursing professionals, and to re-examine the quadruple aims that we have set forth, or the National Academy of Medicine has endorsed in terms of caregiver well-being. Also at the system level, nurse leaders and nurse innovators and nurse policymakers can address the needs of the nurse in a new contextualized way. You know, oftentimes when the nurse clocks out or leaves that shift, there's an assumption that she or he is good to go. And what I am finding through my research and through the nurses that I talk about and my graduate students, that is not necessarily the case. So let's talk about Jacqueline Fawcett's meta paradigm. And I teach theory at the graduate master's DNP level as well as advanced PhD level. And I know that theory doesn't necessarily have the most popular vote in the nursing profession, but I really try to show that application to practice and research. It's not just out in the clouds as a ethereal being. It certainly has a lot to do with what we do as nurses, how we structure our care, how we evaluate our outcomes, and how we take care of patients. So let's talk about what this meta paradigm is that Dr. Fawcett introduced several decades ago. And a meta paradigm in this context means, what is it that makes us a distinct discipline? What makes us different than engineers or physicists or sociologists or psychologists? It's these four central concepts that were afforded by Dr. Fawcett. It's the person, environment, health, and nursing. I've already touched on this, but what are the functions of a meta paradigm? With these central concepts, the so what questions enter into the equation, if you will. And again, it identifies a domain that is distinctive from the domains of other disciplines. Those four central concepts really hone in on nursing at a very abstract and high level, but nonetheless allows us to look at a domain. It also, secondly, encompasses all the phenomena of interest to the discipline in a parsimonious manner, in an eloquent, simple, concise manner. We are able to convey that these are our four central concepts. But as we enter into the conversation today of nurse as person, nurse as patient, that allows us to re-examine this meta paradigm in a new, dynamic, and perhaps helpful way. Another theorist that was really helpful to this discussion in terms of the foundation today was Dr. Conti O'Hare with her wounded healer theory. It was situated primarily in psychiatric and mental health nursing, but I think it really has a lot of bearing on what we're experiencing today. And let me just add that even though technically we are past perhaps the worst waves of COVID, and I hope I am correct in that, we are nonetheless still, we don't want to forget how much nurses endured during that time, and that you can't flip a switch epidemiologically or through the CDC stats or our daily stats of those who pass and those who are hospitalized. Those to me are somewhat not tangential to what nurses are carrying forward from what they endured during the pandemic. And we know this is global. So back to Conti O'Hare. She was a nurse theorist who really tried to really bridge that person and nurse into one conceptual being, if you will. She theorized that nurses became wounded and came into nursing wounded. And we'll talk a little bit about how that became prophetic when we talk about student nurses today and how they're coming to nursing school with some fairly high adverse childhood experiences. She also stipulated and hypothesized that nurses were one who sought healing through the profession. There were some subsequent writing about Conti O'Hare's work that these authors, McCulloch and Chattel, talked about how it led them to confess the nurse in these dual roles as caregiver, healer, care receiver, and those that are wounded. They also stipulated that there's a risk for judgment and stigma. And I'm going to talk about stigma quite a bit in a few minutes, but make no mistake, stigma is alive and well, particularly when we talk about mental health issues. So here I come into the picture a little bit, as referenced, I wrote the book, The Psychological Influence, or the Influence of Psychological Trauma in Nursing in 2019, again, pre-pandemic. It set the foundation for this theory, which was also published in Advances in Nursing Science. And I have included my references to these slides so that you can look those up if you're interested. But what I'm saying in this theory is that you have humankind as well as nurse-specific trauma, psychological traumas. So if you look at this circle on the right side, you see the 7 types of nurse-specific traumas that I talk about. And I'm going to mention those on the next slide. On the left-hand side of the circle, you see this humankind or personal traumas. It could have happened in our childhood. It could be encompassed in our adverse childhood experience scores. It could be more current with private domestic abuse, those types of issues, or being in an accident, or being in a fire or something like that. So humankind versus those traumas that we experience because of what we do on a daily basis. Earlier on in the participant objectives, I talked about these 3 E's of trauma. And again, I'm referencing SAMHSA, the references in the slides at the end or in the reference slides, but you see that there's an event, something happens, and it's experienced by us. And this experience can be very, very unique. We all come with different genetics, different family histories, our own temperaments and personality traits. So, and for sure, our own support system. So how that is experienced is very individualized. But we know that often psychological trauma, especially when we don't recover from it and don't heal from it and take that necessary time, it can have effects, that 3rd E, and create those adverse effects in our lives. And that's when we get into that whole domain of post-traumatic stress disorders. It affects our functioning, and it can be anything from intrusive thoughts, re-traumatization from trauma triggers, nightmares, and so forth. So here are the 7 specific traumas of my theory. And when I talk about these, I know that sometimes we want things in our lives to be orderly with nice, clean breaks. And I would tell you that sometimes these traumas can overlap, but I think they are still distinct concepts. So there's vicarious and secondary trauma. Vicarious really means when we have been co-living patients' experiences, and it can affect our worldview. We become jaded. Perhaps there's a little element of compassion fatigue there. There's also secondary trauma, which I almost see as unavoidable, that co-living the suffering of those we take care of. And we see patients at their most vulnerable. We see them in their time of need. And to be therapeutic, I believe that nurses to a certain extent have to co-live that trauma with them, empathetic responses, et cetera, et cetera. But what we do with that, how we deal with that, how we keep filling ourselves up after being emptied is a real key. There's also historical trauma. We see this particularly with the current discussions about race structural inequalities, social determinants of health. But it's also in nursing that intergenerational trauma, when you talk about bullying and young nurses and new nurses coming into our profession and not treating them so well. Workplace violence is endemic in nursing. And here I talk about the physical and verbal assaults done by patients and families to nurses. There's system-induced trauma. When I was a young undergraduate student at Indiana State University, I read The Cancer Ward by Solzhenitsyn. And he talks in this semi-autobiographical novel about this character who endures cancer treatments. And he talks about his suffering in a duality, partly because of the disease of cancer and partly, or diseases of cancer, and also because of the treatments and what he endures because of the side effects of those treatments. So think about ventilators for the COVID patients that we took care of. Think of all of the things, the restraints we use in behavioral health care and for our cognitively impaired older adults. Second, victim trauma. And I know there are different words to that now. There's second victim phenomenon. Has to do with when there's a medical error made. And it could be a med error, it could be not putting an alarm bell close to reach, et cetera, et cetera. And in my research and my data, I show clearly that that is something that really haunts nurses, even if there's not a harmful or harm done to the patient. They live with that for a really, really long time. Nurses do not forget even the near misses of those errors. Number 6, insufficient resource trauma. This is something that I coined myself, and it has to do with that phenomenon of not having enough staffing, not having enough supplies, not being able to reach other professionals in a timely manner, not having enough knowledge, not having enough orientation, being put in a situation as a nurse that you are not prepared for. And every time I mention this type of trauma to nurses, they all nod. Even before I describe or define it, they all know immediately what I'm referring to. And then trauma from disasters, the triaging of patients, the rationing of supplies and personnel and care, if you will, and deciding, if you will, who lives and who doesn't receive as much care based on the probability of them surviving. As well, being in harm's way yourself because you're in the middle of a disaster. I saw this in a study I did in frontline workers of nurses working in COVID, frontline wave 2, and they would really describe how they would go to great lengths to not infect their loved ones, from stripping in the garage and immediately putting their uniforms and scrubs in the washer and dryer, to physically living in different places so that they did not contaminate or infect those that they loved. So situating the nurse as person-patient. How do we define the person-patient? It refers to the recipient of care. Again, I refer to Dr. Fawcett's brilliance here. It refers to a recipient of nursing, including individuals, families, communities, and other groups. And so I would even expand this as we talk about this context of nurses patient to others helping nurses, organizations helping nurses, but certainly nurse leaders, nursing peers, nursing faculty, nursing student peers, nursing helping nurses, and understanding this new union of beings, nurse and person or patient. I would also specify that in this context, more often than not all, but it's not absolute, but more often than not, we're talking about nurses and mental health patients. The compassion fatigue, the burnout, all of these things that we continue to talk about, the secondary traumatic stress, which is one of my nurse-specific traumas. We also have in the social media this term called quiet quitting, and I don't know how many of you have come across it. I just minutes before this presentation, I saw quiet firing as well, which is a very intriguing concept. But quiet quitting refers to those who just decide to not give so much in the workplace, that they are pulling back. And I think that the discussions maybe haven't encompassed enough of why that occurs, what the rationale for someone to be protective like that, because that's what we're doing, right? We're protecting ourselves because we're tired of going above and beyond and either not being recognized, rewarded, or even sometimes having a supervisor jealous of our accomplishments. So one of my colleagues once had recently had a parent in a hospital, and the parent was just not getting much nursing care. And so she went to the staff and said, why hasn't my mother been walked? Why is she going backwards? And they said, we just don't have enough staff. And I wonder if that is how some nurses are quietly quitting. They have just waved the white flag and they're tired of asking. And I will say, I've had a 40-year career in nursing, and this is a drum we've beat for a long time. We know through many, many nurse scientists' work, Linda Aiken among them, that we know that there are better outcomes when we have adequate staffing. We know nurses don't quit when there's adequate staffing and there's appropriate leadership. This isn't new stuff. It's just using what we know in an informed way and making an economic case for it. We also know nurses are suffering from depression and anxiety, trauma, and PTSD. The COVID study I mentioned before, 55% of those nurses that I surveyed scored probable for PTSD. It was a screen, so clearly we couldn't diagnose over a survey. They clearly screened probable for PTSD. I'm right now in the middle of a fascinating study, a grounded theory study, which is qualitative. I'm doing in-depth interviews for those nurses who are in active recovery from substance use, which is one of my primary areas of research. And I ask them, as this methodology unfolds, one of the techniques is, as you gain data, you do a constant comparison, you go back to the data, and you add questions that may, in the end, add to patterns and themes that evolve. So one of the questions that I've added, because I see these patterns, is, has your career as a nurse and the traumas you've experienced contributed to your substance use? And they will say, oh yeah. And some of the situations that they describe are truly heartbreaking. The lack of debriefing after witnessing incredible suffering and crises, and the lack of just being expected to go to that next room, go to that next patient without really decompressing and debriefing. And then suicide. We know that nurses are at a higher rate than the general population for suicide. I would refer you to the work of Davidson, her brilliant work in terms of nurse suicide, and the articles that she's published and what she's doing right now to help us understand this phenomenon and help nurses get help. There is a stigma though, right? It's been significantly degraded, our mental health during the pandemic, exacerbating long-standing barriers to accessing support and resources. Stigma surrounding mental and emotional health has intensified nurses' reluctance to seek services and resources. We are so used to being only and exclusively as caregivers, as those rendering care to others, that we are very much reticent and hesitant to say, I need help too. I was talking to a student, and she said that at her incoming shift one day, nurses were comparing the amount of alcohol they consumed the night before. And if a patient was saying that, if a patient was reporting that excessive amount of alcohol consumption, there would be a nurse spring into action and say, let me get you some connections with some screening and some therapy. But there wasn't. It was almost as if the nurses were checking each other out to see if their use was out of the ordinary. It was almost like a normative check to see, am I the only one? Am I alone? So there's clearly work to be done as far as overcoming stigma. And I think seeing nurses as those needing care allows us to begin to break down that wall of stigma just a bit. Student and young nurses as mental health patients, as I mentioned, we know that there's been a couple studies, I'm referencing one here, that 40% of nursing students reported an ACE score of 4 or more. So ACEs, for those of you that may not be familiar, are dose specific, right? The higher the dose, the higher our score, the more likely we are to be at risk for chronic diseases, even shorter lifespans. 40% of nurses rating this as compared to 10 or 11 to 13% of the general public reporting 4 or more ACEs. So clearly we have an elevated risk here. We don't know if it's generational, if it's just that Generation Z and the incoming folks are more vulnerable, or if this is something specific to nurses, but clearly implications for faculty. Substance use, I just finished a study with the American Association of Nurse Anesthetists, consultants with them, where I surveyed student nurse anesthetists in school, and the reporting of alcohol. There was a drug of choice, which we know is in nursing. Alcohol is what we choose to use as our substance. It's legal, and a lot of folks will kind of fool themselves into thinking it's not a real addiction. Wine is okay, beer is okay. They also reported in my study of sRNAs that Adderall and stimulants were also used as performance enhancing substances. We have a proliferation of energy drinks loaded with caffeine, loaded with those things that make us more apt to stay awake, et cetera, et cetera. We also know there's a crisis in nursing on the front of nurses, younger nurses leading disproportionately. Statistically higher relationship exists between age and the emotional health of nurses. For all nurses, 30% said they are not emotionally healthy or not at all emotionally healthy. For nurses under 25, that number is 46% as compared to 55 years and older at 19%. So why we're not sure, right? We don't know if we're just not preparing the folks that we're teaching to endure what they need to endure. I was given the privilege of debriefing with some public health students last semester. Their faculty invited me to their post conferences and to talk about my theory of psychological trauma in nursing. And it was about 8 students on a Monday, Wednesday, and Friday, all different groups. And I was really amazed and dismayed at how much trauma those young men and women had been exposed to, either directly or through secondary traumatic stress. So again, these are public health students. They had seen schools where children were choked by other students, thrown into lockers, where they saw homeless veterans who were in dire need of help. One student was punched, so she was workplace violence, and she kept saying, all of the registered nurses would say to me, well, you're okay, right? You're okay, right? You're okay. So I think, again, giving us the grace to say, no, I'm not okay. I need help. I need nursing care. I'm a patient here. I'm a person here, devoid of nursing for a moment. Let's suspend that role for a moment if we can, and let you focus on me in needing comfort and care. So these are just some interventions created by this discourse, right, of nurses, person, or patient. So practitioners, managers, and leaders, quality improvement projects. That's a lot of health systems really look at QI as somewhat of a panacea. But if you want to get the voice of the consumer, get the nurses to talk and allow them their voices to count. Don't just do, this passive listening, but act on what they're telling you and track cost savings through decreased call off and sick times and retention. So use economic metrics. If you use a QI project for nurses, patients, do some debriefing after, and not just for medical errors, but debriefing when it's really a sudden death or an extraordinarily violent patient. Or I know that in mental health and psychiatric nursing, that is commonly done, but we need to do it because we see so many behavioral health patients across the specialties right now. And push for organizational transparency and staffing for nurse representation. Educators, faculty need to be compassionate and debrief with students' emotional well-being in mind. The individuals that I spoke with, the students had various affects during the debriefing. Some intellectualized, some stared off into space. One became very emotional and cried. And the faculty member who invited me did a masterful job of making sure that each student was okay after the session was over. Educators, and I know new nursing that are onboarded as well, so educators and health systems as well, need to think about how we look at our ways of knowing and how we emphasize certain ways of knowing. And I would refer you to the brilliant work of Peggy Chin and Kramer and their work in terms of building on Carper's way of knowing and adding this emancipatory knowledge onto it. Our need for social justice has never been greater, but that should include nurses as well. What we tend to do is make empirical knowledge king. And I think a lot of nursing students want to know the fact, they have to know the facts, right? They have to know the science. It's not a nice to have, but there has to be some balance in there in terms of those other way of knowing, the art of nursing, knowing yourself, ethical knowing, and emancipatory knowing. So knowing that there is a need for that balance in what we know as nurses, I think is also an intervention based on this new discourse. And encouraging trauma-informed language and the behaviors that are infused within an organization. I would challenge organizations and schools of nursing to really take on as an organization a trauma-informed stance. Providing psychological safety for those in organizations and at an individual level is incredibly important, and it's smart business. If you listen to folks and what they know, especially at the point of service, which nurses are, it will tell you what you need to do to make your business better, more efficient, as well as more compassionate. And so I think, the work particularly done by SAMHSA has been, it gives us an incredible framework, as well as other theorists such as Gene Watson's caring theory. All of those are tools and resources at our disposal to make things better. For researchers, we can continue to push funding agency recognition of nurse as patient. So I listened into Shannon Zenk, who is the director of the National Institute of Nursing Research. And she got a lot of questions as they unveiled their strategic plan about, can we apply to funding through the NINR with a grant application to look at compassion, fatigue, and burnout, stress and trauma, and substance use. And right now, NINR is very much in symptom management and investigating disparities in healthcare, social determinants of health, all of those great things. But there's, and Dr. Zenk was very much encouraging us to add that as a concept. She said that the council is going to look at it. So researchers continue to push. For my own work, I've never quite known where it fits. Is it the National Institute of Mental Health? Is it, and I've been very fortunate to be blessed for my substance use work by the National Council of State Boards of Nursing. They've been incredibly supportive of my work in that area, but I situate the nurse as patient. And then researchers can lead teams as the content expert of how global health depends on nurses' health. Policymakers, within organizations, they can examine this ideology, this horrible ideology of the throwaway nurse due to substance use. And here's my confession. When I went into the study of nurses in recovery, there was just this piece that was missing, and perhaps a little bit of stigma on my part. But when I started to talk about these individuals, talk with them, have a dialogue, a narrative, I am left with nothing but respect and honor for those narratives of what they are describing they went through and what they are doing now to regain an unencumbered license, because we are in a regulatory environment. We have to think of public safety. But I also think that we treat these folks in such a punitive way, and that we are lacking compassion for them, especially in areas of recurrence. And abstinence and forcing these different treatment modalities onto them as a one size fits all. So stay tuned for that. I'm in the middle of the data collection. Innovators, we hear innovation all the time right now. It's one of our buzzwords, right? And it's important, right? You know, Johnson and Johnson's having I think a innovator award sponsored by Stryker. We have a newsletter from ANA as far as, you know, Innovation Digest and newsletters. And I'm actually teaching a class on innovation for the first time this semester, learning a lot. I think that's what I like about teaching. I learn along with my students, but we really need to get the nurses at the point of contact. We really need to honor their narratives. They're not just a group. They're not en masse. They're individuals. And the reason people are in hospitals is because of nursing care. They're the first and last point of contact. And we have suddenly, and I guess through so many ways, we've forgotten their role and how much we need them. The other phenomena that we need to get away from are these margarita breakfasts of the night shift, going out for breakfast. But what do those serve, those margarita breakfasts, is that they are debriefed, that they have that camaraderie. One of the other themes that I'm seeing emerge from this nurses in recovery study is I've asked them, what is the one thing that you find the most helpful to you in your recovery? And you know what they say to me? They say the recovery groups that I attend, whether it's just other nurses in recovery. You know, when you tell somebody you're a nurse, it's like, bam, there's an instant connection. There's a bond there. You get it. I became a nurse at the age of 19. And so I saw things that a 19-year-old wouldn't typically see or have to endure. And I felt out of my element with my peer groups. And I wonder if something like that doesn't often occur. And so you go to your peers, you go to these other nurses because you know they get it. They get what you're experiencing, you can empathize with it, and you have that common lived experience. So what can we accomplish by doing this, or by engaging in this new discourse? In practice, we can see the nurse as person, as patient, allows peers and mentors and leaders to consider the effect of nurse suffering on patient outcomes and nurse retention. They're real effects, right? And I know that if you look at a lot of innovators, particularly, and new ways of implementing things, there's always that cost analysis. It's one of the triple aims, right? That cost-effective way. But I think what we're missing is a real opportunity to connect these, right? It doesn't have to be, it can be a win-win-win proposition when we think about caring for our nurses and also economic outcomes. Again, the triple aim has that goal of improving the work life of healthcare providers, including clinicians and staff. In education, faculty really need to get on board with understanding that the students are holistic beings as well. And we have to loosen up a little bit, to a certain extent, some of our dogma in terms of how we teach. I think allowing grace to students and being a role model of caring, being a role model of seeing them as future practitioners in our profession that I love. I stepped away from nursing for about a decade due to having a special needs child, even taught at a top 10 business school in business communication. And I learned to really treasure nursing in a new way. And I think that I learned to treasure nursing students in a new way as well, because they are so transparent in many respects. They come and they imprint on us as clinical professors. They want to learn and they want to care for people. I mean, that is something to really respect, I think. Faculty also need to recognize their own mental health status without judgment. Are you getting burned out? We are on a 24/7, I check my email too much, right? I want to be responsive to folks. I found myself saying, please excuse my delayed response after 24 hours for getting back to them on email. And I'm like kicking myself thinking, that's okay, Karen. You don't have to be Johnny on the spot all the time. I think faculty need to understand that they are vulnerable. having clinical groups is a huge responsibility, right? And a very complex patient care areas, and you have staff who are judging you kind of, and do you know what you're doing? And you have students who are out there rendering care. And so the vulnerability of second victim traumas due to student error weighs on you. So again, I think faculty and academics needs to understand the core of what we are doing as professionals as well. There are many roles in nursing academics as well. There's nurse scientists, there's nursing scholars, there's clinical track, there's tenure track. And I think we all need to appreciate what we bring to the table, and the core essence of our being as nurses should be understood as something that's common throughout. Research. Again, that funding stream maybe can become available in the NINR. So we can look, I presented my theory to an audience in Switzerland not too long ago. And it was made up of physicians, psychologists, other nurses. And when I talked about it, there was some pushback and said, well, this isn't necessarily unique to nurses. And I said, I think it is. I think the constellation of those different traumas, how they present on a daily basis, the intensity of them, I think there is something unique about nurses and this theory that is different than experienced by other professionals in healthcare. We can also build up our evidence through randomized control trials, if possible, testing interventions that would help mitigate the trauma and the stress that nurses go through. Again, maybe even some economic type studies that would look at retention rates as we implement interventions as well. Policy, we can look at micro and macro policy formation, internal organizational policies. If we can adopt a trauma-informed organizational stance and really understand how to recognize trauma. I mean, trauma is throughout any healthcare organization because of the population served. And so if we can see our healthcare providers as also vulnerable to trauma, we can institute policies that would be helpful to them in terms of trauma. I presented to a group in California over the summer, and one of the nurse leaders very, very sincerely said, I don't know how to start. And I really said, start by listening, start by questioning the nurses of what they need. Start by looking at the literature, start by looking at what has been tested in other organizations, because there's some organizations doing some really fabulous things to take care of their nurses. So looking at some of our aspirational health systems and what they're doing that's very effective to retain nurses and to make sure that their workforce is strong. And then there's also some macro level things we can do. In Indiana, the state or the Board of Nursing was actually sued by a nurse in recovery not too long ago for not allowing medication assisted treatment for the opioid addiction she had. And so she was successful. And so they've expanded their allowance of nurses in recovery to include MAT therapy. There's also things going on in various states as far as legislating minimum staffing requirements. It's not going to get into that today, but you all know that there are states where they do have legislated minimum nursing staff ratios. That is not the ANA stance, but some states have adopted that. So in conclusion, I think I'm pretty good on time. There are just some nursing is in crisis, I think, and nurses are suffering. And this quiet quitting, the resignations, particularly for the younger nurses, the demoralization, younger nurses leaving at a faster rate than age groups. Promises from COVID by organizations have been inconsistent and waning in terms of what promises on follow through have been made. I have this new nursing cohort in theory, and they're on their way to becoming advanced practice nurses. And I always ask them, are you coming to a new role with objectivity and that's the role that you want, or are you leaving something that you don't want to have anymore? And often I think that introspection and that reflection is helpful to them to understand that they're moving from one role to a significantly different role. Conceptualizing the nurse as a person and patient offers potential interventions and solutions to the crisis. And practice education, research, and policy. And hopefully, if we set some goals and reach those goals through our interventions, we can see some real accomplishments on a human level and humane level, as well as economic level. So I think that concludes everything that I had to share today. And I'll turn it over to Linda and Megan right now. And I think the chat has got some quite a bit of activity. So
You are right. The chat has definitely been very active. So I want to, first of all, thank you for that content. And that is also reflective from our participants. They have been saying wonderful things, that this is resonating with them, that they love the content that you're providing, that actually it's been much overdue. So I want to thank you for that. I do want to share something that one of our participants shared, and she told me that I could share it out loud to the group because it is a little personal. So I want to read this and get your feedback.
Sure.
She says, I joined this because my experiences being a retired CNS who had to have a lot of care, including inpatient hospitalization or surgical procedures this spring and summer. Disappointed in nursing care at a facility where I used to work. I did take the action of writing a detailed email to the CNO about the good and bad nursing I received, and did get one phone call from the head nurse on the last unit I was on. I think and have seen for years nurses receiving less care than non-nurse patients. What do you think about that?
I think that because we are in a crisis, I think there's two things I want to say. First of all, I think when a nurse is hospitalized or seen outpatient wise, there's this little difference, right? There's this, well, she's a nurse or he's a nurse. And I think that is kind of unfair, because I think we should be seen first as persons and patients, and then maybe, oh, you're a nurse your livelihood is made as a nurse. But I think that this individual's onto something to note that. And I think it's very perceptive of her to note that. I think secondly, because we are in this, we don't have enough nurses. I've had very, very close relatives in health crises, and I have been very disappointed in the nursing care that they received. I think the computers that we have tend to be more of a barrier, and EHRs, I know that there's promise there, but I think how they're rolled out and utilized in our direct patient interactions is, and again, this isn't anything new, right? But we know that it's not helpful in establishing a relationship with those who come to us for care. So I would interject those two things. I think the nursing shortage is becoming more and more evident in the quality of care. And I think that this individual is spot on by perceiving that she, because of her livelihood, her identity as a nurse, probably did affect the care that she received.
We just had someone put in the chat, the quote, "Nurse, heal thyself," is very concerning.
Yep.
And I agree. Another question we had is regarding your framework of insufficient resource trauma. Do you think that the framework of insufficient resource trauma could help organizations realize that nurses deserve to be identified as more than just a labor cost? And how can we bridge that gap?
I do. And I think this onboarding of new nurses is an opportunity. I think that if we could give nurses, some language to use, such as insufficient resource trauma, to say to their supervisor, I was traumatized today because I could not give care to those people whose call lights were on. I skipped this and this and this nursing task because of it. And I'm checking boxes in a long-term care facility that I'm really fraudulent and I didn't do that. And I think that if you can get the new nurses when they're onboarded, as well as maybe annual in-services, to bridge and to give them this language that I am traumatized because I don't have enough resources, but look at what I could have done. if you'd given me more resources. These staffing patterns that are generated, you could start your shift with what, a ratio of maybe 4 or 5 to 1 nurse. And at the end of the shift, maybe 4 to 5 to 1 nurse, but maybe you've had somebody pass, 2 transfers, and admission and discharge. So it's not really reflecting the activity that goes on in that shift. So I think there needs to be a whole discussion with this discourse of insufficient resource trauma entering into our discussions of staffing.
Wonderful. Thank you for that response. And you mentioned newer nurses in that answer. And the next question kind of ties into that. Do you have a hypothesis as to why younger nurses or newer nurses report feeling traumatized more often than older nurses?
That's a really, really good question. I can take a guess or an educated hypothesis. I think that, and I have a daughter who's 22. So I have seen her, and I have two sons, 30 and 27. And there is a marked difference in how they use technology in their personal space and their personal lives. My daughter is connected to it in a much more intense way. I think that their exposure in social interactions is somewhat stunted because of that dependency on technology, because it's not real, right? And I think that's why COVID, we see a lot of discussions right now on the mental health crisis in adolescents and children and young adults. And I think it just hit them because they didn't know how to cope. And so I think this ability to cope, I think educating them, that's why I wrote the book. And I'm not trying to push the book, but that's why I wrote the book. If you it starts with a vignette of me as a researcher earning tenure, and a student comes into my office and she says, well, I'm in 2 of your classes and I should tell you that I was raped over the weekend. And so I talk about the trauma that humankind and that they're going to be exposed to as nurses, because I think if you can prepare them. I did a lot of work early in my nurse scientist career on parental post-adoption depression. And it was a phenomenon that's kind of parallel to postpartum depression or peripartum depression. And nobody had talked about it. And so many of the adoptive parents that I spoke with said, if I'd only known that there was such a thing as post-adoption depression, that would have helped me not stigmatize it so much. I wouldn't have felt like such a monster, because I would have known there were others suffering from this in addition to me. And I could have done something about it earlier. I could have known I was struggling. I would have been more apt to seek services. And I'm hoping that that is the case with our students and our young nurses. If we can tell them, there's going to be these things that might injure you and injure your soul, but there's a path to healing. There's a path to recovery, and we can explore it. And to deny it, I think, or to stuff it, or to look into a bottle of wine after your shift, or having a margarita and then going home and passing out, that's not the way to do it.
I love that. I love that response. Thank you so much.
Mm-hmm.
We had an individual share that sometimes faculty can also induce psychological trauma. She stated that she remembers one faculty person in her senior year of nursing who was not satisfied with post-conference unless at least one of them were in tears.
And that faculty member, and I know there's bullying, and it is disgusting to me when I see faculty bullying students. It's just disgusting. It's the antithesis of what we stand for, right? I used to work with some. They are no longer in the organization, but I think it's unfortunate. And I guess there's always a power gradient in organizations, right? Be it an educational organization or a healthcare facility. And those power gradients, there should be some mechanism for holding people accountable. I know a lot of leadership leaders who need more development than those they supervise. And so I think that in tandem, there's a lot of caring faculty, a lot of, like the public health faculty, Dr. Carmen Jones I mentioned, who really used the art of nursing, her own knowledge of herself, her ontological self, who is so different from that person. And I guess the only thing that I hope came from that was that those students maybe had a different instructor along the line that could role model better values and better mental health, because there's clearly something wrong with that faculty who feels that need to be so sadistic.
Yeah, that's wonderful. Thank you for your answer. Um, and I think that goes, I think I could say a lot here, but I'll just keep moving on with the questions. I think we have a few more minutes, and I want to thank everyone before we get into more questions, because everyone is sharing so honestly and openly in the chat feature. So I really do thank you for being open with this group. And as we know, change in our profession is really slow. So Dr. Foley, what do you think would be things that we can do now to improve the work environments and the cultures? Things that could have some more quote unquote immediate impact while we're working on these things that take a longer time span?
I think there needs to be a commitment from those in power. I think we have a ton of solutions. I think some are evidence-based. The work of Bern Melnick is brilliant in terms of building resilience, but I think that organizational context has to have fertile ground for that resiliency to bloom and blossom. I think, the traveling nurse phenomenon is a lesson for us, right? Healthcare organizations are paying big bucks for traveling nurses, and a lot of the younger nurses love traveling nurses. Fits them well. But I think there's a cost to the organizations long term. I think the people in power I think there's a reckoning that needs to be made with them. I was going to write a blog, I never got to it. Take your CEO to Workday or CFO to Workday. Let them see, and I think engineering's piece in healthcare is helpful, but nurses, I think, are queen and kings. I think they are the ones that are really have the answers, but maybe nobody's asking them. But I think those in power really need to take a good examination of how to do things different, and it's a win situation for them as well. I don't know how to make that happen. I think nurse-led teams is really important. I think nursing leadership can do a lot in terms of changing the paradigm in healthcare systems. And I think, there's this piece that's missing. I don't want to say in society, but there's this piece of authenticity missing. It ain't great in healthcare. Healthcare is broken, right? We have the solutions. And a lot of what I've said today is novel and new, and some of it's not. We have the solutions. It's just enacting those solutions by the people in power and really providing evidence that it's a win-win for everybody.
Thank you so much for that answer. Unfortunately, we're not going to be able to get to all of the questions that are still lingering, but we still have coming in through the chat how thankful everyone is and how great this presentation has been, and so very timely. So we want to thank you for sharing all of this expertise with us today. I did share in the chat Doctor's email address. She is very willing to connect with you if you want to email her if you did not get your questions answered today. We want to thank you all for coming today, and we are grateful that Dr. Foley took the time to share with this audience, and we definitely look forward to hearing more from you in the future and all the great work that you're doing to move this work forward. We hope that you enjoyed this webinar. As a reminder, 1 week from today, we will email you a link so that you can do the evaluation to obtain your Nursing Continuing Professional Development Certificate. Be sure to check out Sigma's upcoming webinars and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars are on the Sigma repository for your access. Thank you for joining us today and have a wonderful day.